And so now with that, I turn it over to Edith, who will provide us more information about older adults. Edith.
Thank you so much, and good afternoon, everyone. Année, bonjour. I'm Edith, and I'm coming to you from Sault Ste. Marie, which is within the Robinson-Huron Treaty Territory. And I am honored to be here, to have been invited to share a little bit about the work that I do for our communities. I work for a North Shore Tribal Council community that services 7 First Nations along the North Shore of Lake Huron in Ontario. So I've been doing this work for a number of years. It started out as through funding from the LIN Aging at Home program and looking at how do we ensure resources for our First Nation elders. And so with the funding, it was often joked that my title quickly turned into the aging coordinator, which I was obviously not too happy with. So we are evolving from that initial growth within our organization and building on our home and community supports within the 7 First Nations I work with. So it's been a long journey, and I have reached out to our elders in the community to help me with this job. They have been my guide throughout the enhancements to identify the gaps in services, the resources that are required. And so we've been together for a number of years, and coming together in the virtual form, I thought it would have been great to have joined you from one of our communities and with the elder at his sacred fire, which he offered. And sadly, Dr. Rastoul mentioned the lack of connectivity in our community. So we didn't have internet there. So we're resorting to being more in the city to join today. But it does speak to the lack of resources within communities that we struggle with. So I say Chimigwech to Dr. Rastoul for actually setting the context of what I would like to share and build upon around the lack of resources for home support services within our First Nation communities, and the work that we've done to try and enhance those resources. Some of the struggle that I have had over the years is trying to access external resources, bringing into community to support individuals in home. There has been some struggle around the funding envelopes, the assumptions from external partners on whose role is it to come into community to provide services. And these have been ongoing challenges that I've had with trying to introduce these services to communities, which our communities should be able to access. And sadly, that has not always been the case. So the work that I've done, and I shouldn't say the work that I've done, the work that we've done has been to build those bridges with those services. But quickly realizing that we have to rely upon each other within communities. We have to rely upon our resources and all of our providers, and to build that capacity to take care of our own. And I think that's come to light with the pandemic planning that we've done at the community level. I've been invited to sit at a local LIN planning table and quickly realized that the conversations there and the planning in place did not reflect the needs within our communities, or would not meet the needs in the event of an outbreak. So what we introduced was an additional structure with the inclusion of an Indigenous task team for the North Shore Tribal Council communities. And what we did is we brought together our First Nation health directors and community partners to start a local response to planning. And when we started the conversation, we knew that statements were being made that in the event of an outbreak in one of our communities, there would be resources from Health Canada. The local providers would step in to assist. But what we realized as well is that we didn't know what that meant. So we wanted to really build upon our planning for a local response. And we have met every day from the onset, or every week from the onset of the pandemic, to start that planning at the community level, but also within our agency to look at how do we support, how do we begin planning, who do we invite to the table to help with this planning, so that what we put into place was reflective of our realities and what resources were available. So I'm so happy to say that we did get an amazing response from our local partners, the Public Health Unit, Indigenous Service Canada, Health Canada reps, our Ontario Health North reps, to assist us with that planning. And we identified 6 pillars to plan around, and recognizing that all of our escalation plans and processes would have to include our First Nation communities, as well as what resources were at the community level to support this planning. And again, it was more to realize that the response had to come from community. So I'm happy to say that we're still together as a task team every Monday morning. We come together to do that planning. But it's more of a reflection on how we've come together as communities to address our home care services, and really building upon that that collaboration and building capacity in community as well. So I use this as an example of trying to ensure seniors are receiving services within their homes, and who is available to come to the table to ensure those resources are available. So I commented on the Senior Patient Advisory Council that was established to support that planning, and they were the ones to help guide that growth and identify the resources that are needed. We have a number of initiatives underway, including what does palliative care look like in our communities? What resources do we have to wrap around families and their loved ones when they want to pass at home, as opposed to in hospital or within long-term care? So that is an example of how we've realized that the answer is within the communities to do that. And we have maximized on the knowledge and the strengths within us to do that work, and just building upon that relationship that we have to look at other areas of needs. So really the current state, and within looking at the pandemic and how do we respond, we have realized that we have limited resources, but the collaboration at the community level has been amazing. And I'm always willing to share that approach that we've taken, not to say that we have it all figured out by any means, but I think we can all learn from one another. And that's really been my goal, is to share the work that we've done with other First Nations to assist in that, in those efforts. So I'm going to stop there. If you have any questions, please feel free to reach out to me, and I look forward to continue sharing the work. Miigwech.
Thank you so much, Edith. I will ask Laura to please unmute and go ahead, and looking forward to Q&A with all of you.
Thanks very much for having me. So when we're looking at the question of how are older people faring in the time of COVID-19, it's really hard not to, get caught up in the long-term care question. And I know that my colleague Jane Meadus, who is on the call, will be speaking about the issue of long-term care in particular. So I'm going to leave our conversations about long-term care to Jane. And so what I thought that I would speak about a little bit more today is talking about how older adults have experienced social isolation and elder abuse in the time of COVID-19. And I just wanted to give you a little bit of a context of, where we were before and what COVID-19 has done, during the time that we've been really isolated in our own homes. So I propose to just kind of talk in my session about kind of where we were and where we are and what it's looking like that we're going to be going to from here. So I also just wanted to start off by giving just a very, very brief overview of the work of Canada's advocacy organization, which is my organization, CanAge. And during the time of COVID-19, we decided that the most effective thing that we could be doing to support older people was both answering the phones, and we certainly had hundreds and hundreds of seniors and family members reach out to us, and we tried to help and support and navigate them, but also to address the significant gap that we have in Canada around not having a plan for aging. And so Canada has been unique in OECD countries, and not in a good way, by not by essentially being the only country without a plan for aging. And so over the course of about 5 months, we did sort of thousands and thousands of hours of work consulting across the country in every jurisdiction with all political parties, working to crunch the numbers from key stakeholder organizations to review the myriad commissions and inquiries that we've had in the space of older people. And over that process, we came up with 6 compass points, and they are what you see here: violence and abuse prevention, optimal health and wellness, infection prevention and disaster response, caregiving, long-term care, home care and housing resources, economic security, and social inclusion. So I'm just going to touch on the points particularly around V and S, our violence and abuse prevention and social inclusion. So we're always trying to ask this question from a problem-solving perspective. So CanAge is very much focused on trying to move things forward and sort of make things better. But it is helpful to frame it within the context of age inclusivity. So in our roadmap for Canada's seniors, we again had 6 compass points, which you've seen, 40 issues across the VOICES compass points. And you can see issues 1 through 5 are here. And then if you go online onto our website or download the PDF, you will see that under each of those issues are a series of very specific policy recommendations that speak to the experiences both pre-COVID and during COVID-19. And so we have, again, 6, 40, and 135 very specific recommendations. So what was happening prior to COVID-19 in abuse and neglect, and then what's been happening since? About 1 in 10 older people will admit to having been abused and neglected pre-COVID-19. And like other forms of abuse, certainly we know that it's underreported. In 2015, we did a large community prevalence study called Into the Light, and I was part of that research team that looked at abuse and neglect in a number of different perspectives. So we looked at it from a financial perspective, emotional and psychological issues. I looked at it from physical abuse, institutional abuse, and that's certainly one that I know my colleague will speak about. And then also looked at it from the perspective of sexual abuse and neglect. It's important to remember that that study was limited only to members of the community, so it was not in an institutional setting, so it does not capture really that the experiences of people who live in long-term care. And it only was a response system for people who were themselves mentally capable of answering. So we know one of the big predictors of social vulnerability or abuse is whether or not you have cognitive impairment or not. So it's a limited study. And even within that, it's about 1 in 10. Well, we actually believe if you crunch the numbers in a number of different ways, we get to about 1 in 5 or 1 in 6 people will experience abuse and neglect. So it's a lot as an older person in Canada. We don't have capital E evidence. And when I say capital E, I mean it's the kind that you would hold up to a sort of scientific review, because the time of COVID-19 is still ongoing and numbers are expanding in contraction. But I can share with you some early information and early data that we have, which has been shared with the Senate and shared with provincial and federal governments in other ways, and certainly is a real challenge right now. Give you one example, and I'll just give you the Ontario example, but I'm happy to talk about other provinces and territories as well. During the time of COVID-19, we have seen a stark increase in 2 types of abuse and neglect in particular that we know about. Again, it's a hidden issue. One is it's been a rise in financial abuse. In some cases, we've seen, massive spikes, particularly in frauds and scams, often directly related to COVID-19, like actual COVID-19 benefit frauds and scams, or focused specifically on COVID-19 and money. We've also seen a significant rise in physical abuse, it appears. And so, we understand that often within the context of either people who are now locked up with their abusers, with people who were not able to go into the community in the way that they would ordinarily go to get resources and supports. The bridge games aren't happening. The walking club isn't continuing. And some of the, religious or faith-based organizations, which often provide some needed supports to some members of the community, are closed. So we're seeing that people are kind of locked up with their abusers and without those regular outlets. We're also seeing folks move home. And if we think about kind of the portrait of the abuse, about 2/3 of all elder abuse and neglect is perpetrated by those closest. So, caregivers, friends, and families are the overwhelming folks who are perpetrating elder abuse and neglect. That is now only offset by financial because of the stark increase in financial abuse. So it's not that there's less of the others, it's that there's more financial. And now it's about 50-50 stranger abuse and neglect for financial as it is for in-person. We've also been surveying across the country in terms of looking at both the response-based organizations and police organizations. And what we've seen, again, anecdotally here, doesn't live up to capital E evidence, but it is certainly persuasive, is that there's been a huge increase to resources for community-based organizations. So in BC, it might be, Seniors First BC or the Sail Line. In Ontario, you're looking at the Ontario Elder Abuse Prevention Ontario organization and similar. So giving you an example, there's been on average about a 10-fold increase in reporting to community-based organizations by seniors of abuse and neglect during COVID-19. But there has been a reduction, it appears, through early information and reporting to police. So people are more trying to reach out to community-based organizations and feel less comfortable having police involved. And that's a very interesting outlook. And it looks like, people are feeling less safe. Certainly leading off into our conversation, we are also very, I think, scarred by the stark realities of the types of institutional abuse and neglect that we have seen during the time of COVID-19. And certainly the military whistleblower report will never again kind of let us think about long-term care in the way that we did before. And it's important to know that many long-term care homes have done as great a job as they possibly can, and that there's wonderful long-term care homes, but there have been some where the outcomes have been horrific. And I just want to conclude the last couple of minutes by talking about social inclusion. So elder abuse and neglect and social inclusion are certainly related to each other. And we have seen a sharp increase in loneliness and exclusion from community based folks as well as those in long-term care. So again, my colleague will speak more about long-term care. So I just wanted to share with you that, our issues that we included here that you can see are around things like loneliness, seniors and technology, transportation, ageism, Indigenous seniors issues, and intergenerational issues, all of which speak to that notion of social inclusion. One of my very first comments when we heard, in this case, it was the Ontario Premier, Doug Ford, say that he was going to put an iron ring around seniors. And then the next thing I heard was Dr. Theresa Tam talking about all people over the age of 70 should self-isolate. And I thought to myself, I wonder how the boomers are going to do with this, because for many people, recently 70 or above, they wouldn't necessarily consider themselves older people, and they may have never considered themselves as being vulnerable. And yet now there's this new narrative that because of COVID-19, they have increased vulnerability. Layer that onto people with pre-existing health conditions, the folks we're talking about, at this session right now, you have increased worry and increased isolation from broader community and existing supports. And we heard that with my colleague who was talking about how they had to pivot from the then named Schizophrenia Society, and even my colleague who just preceded me talking about community-based resources. We've needed another way of function, and that's been a real challenge as we've gone forward. So just to wrap, what can we do and where are we right now? The Voices of Canada Seniors is available for download, and it's also available in various accessible formats on our website. I've put some resources here, and again, happy to share the slides as well, of our organization and the Canadian Network for the Prevention of Elder Abuse, which is a great organization to go and it will help to locate you into other areas. And also the Canadian Centre for Elder Law has got lots more information on some of these issues. I would love to invite you to check out our resources and tell us your story. So one of the most important things that we do is collect stories, and we will have one of our trained team members, many of whom are actual trained social workers, reach out to you or any colleagues you have and walk through our process, whether or not you'd like help and support navigation. We try to assist as much as we can one-on-one. But if you have a story to tell, we will collect that and then work with you to see if you want to disclose names or not names, and so on and so forth, because we try to make sure that we bring the voices of Canada's seniors and caregivers and supporters into all of the work that we do. Got a lot of recordings and webinars and YouTubes and every other kind of great thing as well. So I just wanted to close by offering those resources to you. So again, what have we seen in some? We've seen a sharp rise in abuse and neglect, a sharp rise in social isolation. And unlike many other issues that have had addressing the violence, for instance, against women, and violence against Indigenous people and violence against children, have now had something like $743 million given to it cumulatively since the time of COVID-19. And there's been precisely $0 given to abuse and neglect, absolutely zero money being given to abuse and neglect on the issue. So we see a stark differential impact when we're looking at violence of older adults. Thanks very much. Happy and to enjoy our conversations together. And I know that my colleague Jane is now on the call as well.
Laura, thank you so very much. And Edith, we again gave us a lot to think about. I am glad to be able to turn it over to Jane Meadus from ACE, who we're so glad is able to join us today. And Jane, I'll invite you to unmute and start your video and carry on the conversation that we started back with Edith and Laura about older adults.
Okay, so you can see me, right?
Yes, and we're so happy to.
Okay, so thank you very much for having me. Sorry about that. There were technical difficulties. I was here the whole time. And I'm glad I didn't do a PowerPoint, so I can sort of just really focus on a few specific issues and kind of consolidate what I was going to say today, so we can get onto the Q&As, etc. So, when it comes to people in long-term care, there's sort of three main issues that I was going to talk about today. One is access to care. One is consent and capacity issues in long-term care, and the other is detention in long-term care. So, prior to COVID, these were all issues that we would see all the time in long-term care. People had issues getting access to proper care. People weren't, the homes were not getting informed consent from residents or their substitute decision makers, and people were being detained illegally. And, I'm a lawyer, I work in Ontario. So, my practice is in Ontario, and my experience is in Ontario, but most of this would fall in similar ways across the country. With respect to care, we always had issues around people getting care, there not being enough staff, people not getting, being rushed through their care services. And of course, once the pandemic came, this became markedly worse. One of the reasons is in most places, caregivers, so family caregivers were asked to leave, or told to leave, and were barred from homes. And they were really propping up the system that was already very thin. And they found that, they lost this care, plus the staff themselves were getting sick or were quitting. And so we had a huge staffing issue. This is being dealt with in different ways across Canada. But it has taken a lot of advocacy by very, very different groups to try to get more care. In Ontario, we have a promise of 4 hours per day per resident, but that's not until 25, 26. And that's not going to help today, and it's not going to help with getting staff today because there's no staff to get. That's the other problem, is we don't have enough staff. So moving forward, one of the things we have to do is to ensure that people are going into this as a profession, and that it's a profession that people want to work in. And right now it's a poorly paid profession. It's very difficult. It is, quite problematic given COVID and people getting ill. So they're going to have to change that. With respect to consent and capacity issues, when people go into long-term care, they often lose their autonomy. The homes stop talking to them, and they will provide treatment to people without getting consent from capable people. And they will go to substitute decision makers, even though the person isn't capable, or they just, they don't bother getting consent at all. This increased during COVID. We do know that a large portion of people in long-term care do have mental capacity issues, although they are never or very rarely formally found to be incapable. They're almost never provided their rights, as certainly in Ontario, we have a right to challenge those findings of incapacity. And because of family members not being in the home and substitute decision makers not being provided with information, there was has been a absolute breakdown of any kind of obtaining of informed consent in many homes. And we heard throughout that people were not hearing anything about their loved ones in the home, despite the fact that they would be the substitute decision makers for them. There's a recent article published with respect to the increase in the amount of antipsychotics during COVID in long-term care homes. And that was because people were getting agitated. And my guess is that those homes were prescribing those medications without getting consent, and that's illegal. And so moving forward, this has always been a problem, and we need to train and make sure that the staff, including the physicians and the nurses, are getting informed consent, which is the law in every province in Canada. You may have different laws, but everywhere you have to get informed consent from a person or their substitute. And this really just isn't happening. And it went so far as to have the homes were making decisions to not, for example, send anyone to hospitals. We had homes that did that, not treating people. And there's been a real failure, not only in the consent issue, but really in the way that we're treating seniors. With respect to detention, pretty much across Canada and across much of the world, although certainly the Western world, people in long-term care have been detained in their homes since March. In Ontario, since about March 22nd, perhaps a little earlier, but it was officially March the 22nd, people were detained using a directive from the Chief Medical Officer of Health in long-term care and retirement homes. That was about 140,000 people who have been detained. Long-term care residents were detained until September. At that time, they were allowed out for short visits without any interference for about a month, and then that changed, and they now again have to get consent and are again being detained if they're in a orange, red, or gray home zone, plus of course if they're in lockdown because of an actual outbreak. But people who are not in outbreak are being detained, and the way that they're doing this is not in accordance with the law. It's not in accordance with the charter. Detention in long-term care has always been a problem. Ontario, as far as I know, is the only province that has any kind of detention law on the books, but it is not enacted. So people across, seniors across Canada are detained in a variety of different kind of care situations without any legal authority. It's entirely illegal. It's not charter proof. This is something that we, again, moving forward, we have to fight. And even with respect to the detention now, yes, we understand that people are, there is risk to people in long-term care who are very susceptible to these diseases. It's absolutely true. And we have to make sure that people are safe. But I'm not sure that, detaining 140,000 people is the way to do it. And so I think we really have to think about, how are we treating seniors? Are we treating them differently in a way under the law? Because people in other sectors where there are detention orders, where there have been issues, they're being detained in using an order by the Chief Medical Officer of Health, and those orders are challengeable in Ontario. But for people in long-term care, it's just sort of a stroke of a pen and you're all detained, and there's no way of challenging that other than going to court, which is very expensive. So I think that we have to really look at the rights of seniors and ensuring that we're respecting those, and ensuring that, moving forward, that we're not simply being paternalistic and detaining people against their rights. And if you want to see what the residents think of these things, as you may know, the Ontario has a commission into long-term care into COVID, and the Ontario Association of Residence Councils did a submission to them, and you can hear the voices of the people and how they talk about being caged and feeling like caged animals for the last 8-9 months. And I think it's not a good reflection of society where you're detaining such a large number of people. We have to do better. So I'm going to stop there. Thank you.
Well, all I can say is, wow, Jane, thank you so much for opening up our thinking around this. I think these are a lot of things that we're not thinking about when we're supporting our diverse patient communities and what they might be going through. So I really thank you so much for joining us and being flexible with how to do that. I'm very grateful we got to hear your presentation.